Hello everyone, welcome to this ERS webinar on the recall of Phillips CPAP and ventilator devices and the ERS statement on this. The aim of this session is to discuss the impact of this problem on clinical teams and importantly on our patients and how we move forward. I'm Anita Simons, current president, and we have with us in this webinar Professor Randarath and Professor Shiza from our sleep assembly, doctors or professors Vink and Doverman, leads in non-invasive ventilation from the Society, Professor Ursu, who will talk about pediatric aspects of sleep, and crucially too, Luca Roberti from our European Lung Foundation Patient Advisory Group, and he's also of the Italian Sleep Apnea Patients Association. It's very important to say from the start that we may not have answers to all questions. In this area, we have many known unknowns and unknown unknowns, and we're in a situation of balancing risk, but in some situations, it's very difficult to quantitate the risk. And so we'll try and set this in context, but we felt the most useful thing when we're in this difficult situation is to discuss what individual teams are doing and how they're managing the situation. So we're going to start with a run through of each of the areas in adults, CPAP, non-invasive ventilation, pediatric aspects, and the patient views, and then we'll have a panel discussion and welcome your questions. So we'll kick off with Professor Randarath. Thanks, Winfried.
Thanks, Anita. It's a pleasure to be here and to participate in this symposium or this webinar. And thanks to all participants. It shows how important this topic is, that we have so many participants only a few days after announcing this webinar. Thank you. My job is to give you some introduction and show you what we know at this moment. And to be honest, we are very limited in our knowledge at this time, but we will try to do our best to give you this information and to also to guide you a little bit through the ERS statement, which was released very soon after the announcement by the manufacturer. What is the problem? The sound abatement foam inside the devices has been shown to degrade through a process of hydrolysis. The foam is made from polyester polyurethane, and it has been found mainly during routine services that there is some degradation leading to grainy materials being released, and they have been found in the mask or in the tubing of the devices. Potentially, there are also volatile toxins, as the chemicals include substances which can transfer to substances with potential carcinogenic risk in animal trials. So these are very preliminary data. These are findings from preclinical situations. However, these materials have been classified as bio non-compatible, so they are not useful for humans, for human devices. At the moment, it's not clear if these volatile toxins are released in substantial amounts and over which duration they are set free. So we have two problems: the grainy materials, the particles, and on the other hand, the potential of volatile toxins with potential carcinogenic risk. This degradation has been reported in quite low number of devices, 0.008% of the devices investigated. However, there might be also a number of unknown devices also affected with this process. The newer machines of the manufacturer Phillips use silicone-based foam, which has nothing to do with polyester polyurethane. So this should not be a problem with these newer devices. And also other manufacturers report that they also use silicone devices, although we do not have the information from all manufacturers. So what do we have to state as clinicians, as scientific society? On the one hand, we have to balance two potential or real risks. On the one hand, we have the potential risk of acute and chronic exposure to toxins, especially the particles, but more importantly of the volatile toxins. This is the one hand, and we cannot really estimate how big this risk is. On the other hand, we have the acute and chronic risk of the cessation of treatment. And we know much more about this risk. We know it from sleep apnea patients who have a driving risk, who have a risk of accidents at the working place, who have risk of daytime sleepiness, quality of life, and so on. And we also know about the risk for patients who interrupt their non-invasive ventilation. So we have to balance these two risks. And at the moment, we do not have evidence of any acute life-threatening events. We cannot precisely quantify the risk of each treatment option. And therefore, we have decided to put the main message in the statement that patients should not stop or not change their treatment even they receive a notification from the manufacturer. Maybe you have seen in one of the first released information from the manufacturer, it was noted that the patient should stop their devices, their treatment immediately. And we recommend not to do so, but to contact the physician in the first step. So the first aspect is that any decision should be made on an individual basis, and that it should be done by a physician closely together with the patient. The patient has the right to get all updated information as we get them ourselves. And because it's necessary that the patient can fully participate in this decision and in the balance between the two risks. The medical recommendation done by the physician should take into consideration on the one hand, the impairment due to daytime sleepiness, accident risk, comorbidities. It should also include the disease severity based on the HI, the hypoxic load, the hypercapnia, and also the objective impairment in daytime performance. On the other hand, we have to discuss the risk of long-term treatment with toxical devices. This is especially important, for example, in children who have may have a long period and may be more sensitive to toxins as compared to older patients. So therefore, we have some examples for possible decisions. One decision can be continuation of the treatment until a comparable alternative is available. And this should be the case in patients with severe breathing difficulties or ventilatory failure, patients with severe subjective impairment of quality of life, daytime sleepiness, or accident risks, or patients with significant comorbidities. Another possible decision can be to swap to an alternative treatment. For example, patients with mild and moderate symptoms, no substantial cardiovascular burden of the disease, or no relevant respiratory disturbances. These patients can easily be switched to mandibular advancement devices, for example, or positional modifiers. And finally, it can also be discussed to interrupt the treatment until the device can be replaced or repaired for those patients who have only mild symptoms and mild disease burden. Due to the high number of patients treated, it will be impossible to exchange the devices under in-lab supervision immediately. Therefore, swapping of non-invasive ventilation, we state that swapping of non-invasive ventilation must not be performed without supervision. We recommend to go on with treatment until the option of supervised swapping is possible. Exchanges of sleep apnea devices may be reasonably exchanged without supervision in some cases. However, in these situations, the evaluation should be performed at the earliest possible date, and this includes also the swap to other treatment options, for example, mandibular advancement devices. As long as patients are advised to continue with their current devices, the use of inline filters is recommended. However, we have to consider that we should use accepted filters, not only filters which can be bought, non-medical filters and so on. So we have to focus on the resistance of the filter. It should follow the recommendations of the manufacturers. Patients should not use humidifiers together with filters because this will increase the resistance after a short period of time. And we have to discuss, we do not really know how long the duration, the life expectancy of these filters would be. It will definitely change according to the pressures, according to the humidification, to the fluid exhalation of the patient, and so on. So these are my first information about the situation as far as we know it today and what we decided to put in the ERS statement. Thank you, Anita.
Yeah, we don't hear Anita.
Oh, please go ahead, Marika.
Okay, yeah, thank you. I'm Marika Duifman. I'm a pulmonologist at the University Medical Center Groningen in the Netherlands. And I would like to discuss a bit the view we have as the non-invasive ventilatory support group of Assembly 2. We are faced with this issue because also the ventilators, the A30 and A40 and the Trilogy ventilator are subject to this foam issue. So we are facing this issue, and actually, I think I can click myself. Yeah. Actually, I noticed this morning on a busy outpatient clinic with all patients on home ventilators that we are more concerned compared to the patients. Especially in patients with ventilatory failure, it's very important to balance the risk, and the risk of stopping therapy is for these patients, I think, unacceptable. And also the patients told me that they will not accept the risk of stopping, so they simply cannot. Because and the second thing is that the risk of this issue, the risk of these toxins, as Professor Ronald explained us very well, is not very known at this point. We are not aware of the true risks for our patients with this issue. So I think for the patients on home mechanical ventilation, our advice is do not stop, absolutely do not stop. Just continue your therapy. I have some issues to discuss, I think, especially for this group of patients. When we are gonna replace or devices have to be repaired, there will be a discussion about priority setting. We also have children on 24 hours invasive home mechanical ventilation. Will be talked about later also. We discussed the issue of filters also in the Netherlands. And I think there's a lot of discussion possible about this issue with filters, because our experience that placing filters in between, you cannot do that simply and then rely on that the ventilation will be the same. There are changes in resistance and you might have to change settings, and you have to supervise this. So that should be in hospital or outpatient with telemonitoring. That takes a lot of time of our teams. For the home ventilators, the filters are only approved for the use with the Trilogy device and are difficult or even impossible with the A40, A30 device because there's an inbuilt humidifier over there. And for most of our patients using high pressure ventilation, it's almost impossible to use their ventilation without humidifier. They will not comply with that. There was a discussion about how often should we change the filters, and I think also an important point with the filters is that it might filter particles, but we are absolutely not sure that it filters the volatile toxins. So, and I think the discussion with the particles is one. I have to say that we are using the devices for more than 10 years, and I didn't have a patient that saw particles. And the volatile toxins are, I think, impossible to see and maybe the most dangerous. So the filter will not solve our complete problem, and you might decide to use them, but be careful that you take those points into consideration. We were thinking, but that's open for discussion, whether as home mechanical ventilation group or home mechanical ventilation centers in Europe should think about registration of these side effects in our group of patients. And maybe also think about, do we need additional data on clinical effects? Because most of the information given by Phillips until now is only the measurements of the lab measurements on the devices. Are further studies necessary, and who's going to do that? So those are open points for discussion. I think the main point of view of our group is that we are completely sure, or we are completely convinced that we should advise our patients absolutely not to stop their ventilatory support, and we'll wait for further information.
Thanks, Marika. They are all excellent points, and I see queries coming up in the question box. So we will come back to these points undoubtedly. So let's go on first to our last two discussions. So Rafika and pediatric aspects.
Thank you and good evening all. So I will review the recommendations for providers of children prescribed recalled Phillips Respironics devices. So the recommendations that I will discuss were compiled by a group of pediatric sleep physicians from North America. We have reviewed these recommendations with the ERS pediatric sleep group and working on our own, but there are different based on the countries that maybe I will try to answer during question time. So as we heard that these devices have caused some risks, but the impact of the risks on children are not stated yet by the company. And although the initial suggestion was to stop, as we also heard in adults, for children this recommendation will vary based on the national health regulatory agencies and the advice from the respirologist. I think the main recommendation from the pediatric group is that this is a shared decision-making model, that the patient and family, with close guidance by the child sleep respiratory provider, will decide whether to continue or discontinue these devices, and I will try to give some information regarding that. And clearly, the continuation or discontinuation of the PAP must balance the risk of discontinuing the therapy in a child with an underlying sleep condition against the risk of exposure. And as also has been alluded, evolving nature of this recall may cause changes in these recommendations. So the shared decision-making model includes the patient and family and the medical team. And the following points need to be taken into consideration in children. So one of them is adherence. If the child is already not adherent or adherent and not maybe complying with the other recommendations, that could be an issue to take into consideration. Of course, the most important of all is the severity of underlying disease. And this is not only measured by the numbers of apneas and hypopneas, but also the gas exchange, quality of sleep, and overall medical complexity of the child. So if a child has a medical complexity such as syndromes or neuromuscular disease, the treatment decision may be based even on a less severe sleep disorder breathing. Another maybe a different point in children is the severity of daytime dysfunction without treatment. Although we see the risks of drowsy driving and excessive daytime sleepiness in older adults, especially if they're obese, the problem that we see more in children is with the school performance and behavior. So these need to be taken into consideration because there may be some patients who doesn't have severe obstructive sleep apnea based on the polysomnography, but have significant daytime problems. And local availability of alternate devices or treatments are also important. And we see this in Europe. In some countries, newer devices are available and approved, but in some countries they are not. So that, of course, this will be a point to be taken into consideration. And these all need to be, of course, balanced against the acute and chronic symptoms of foam toxicity. So based on those considerations, the recommendation, the provisional recommendation is that to answer those two questions. The first one is, does the child using recall device have any of these diagnoses or comorbidities? So these include neuromuscular disorders with hypoventilation, central apnea syndromes or hypoventilation disorders, chronic lung disease with chronic respiratory failure, cardiovascular disease and or pulmonary hypertension requiring PAP therapy, or severe upper airway obstruction with gas exchange abnormalities. So these children will be children either who had adenotonsillectomy but have persistent obstructive sleep apnea that is severe, or patients who are not amenable to adenotonsillectomy because of underlying craniofacial or other genetic disorders. The second question to ask is that, does the child have marked improvement in daytime dysfunction related to using recall device? As I mentioned earlier, this is a significant consequence of sleep disordered breathing in children and affect the children developmentally. So if the answer to either of these questions is yes, then the suggestion from the experts is to suggest to continue using the PAP device. But here is a question, how long? So some European countries set that time limit to 3 months. Some hasn't, but it's a continuous, it's of course a watchful waiting time and require close follow-up of the patients, and 3 months may not be unreasonable, at least to reassess the children. And then they are supposed to register for repair or replacement. In some countries, the replacement can be done through insurance if the device is older than 5 years. And then, of course, to assess routine cleaning regimen that complies with the recommendations of the country. For ventilator devices, sterility, so that's what's mainly used for invasive ventilation or life support in children, consideration of inline bacterial filter to mitigate risks related to solid foam debris is recommended. However, as just mentioned, these filters are not thought to be effective against volatile organic compounds, and this is especially a concern for children who are on continuous ventilatory support. If the answer to those two questions that I just mentioned, no, then there can be a suggestion to either to discontinue the device and discuss alternative treatment options with the child and family. If this is the case, then and also the children have significant daytime symptoms, then offering a school note to family and the child about PAP therapy suspension could be advised, as these children may be prone to daytime effects. So I will just conclude that we need to document this shared decision, both in the medical chart of the patient or the electronic medical records, and continue to monitor the situation closely. Thank you for your attention.
That's great, Rafika. Thank you very much. So we'll go straight on to Luca.
Yeah.
Thanks, Luca.
Thank you. I want to thank ERS and ELF for the invitation. My presentation is the point of view of the patient. I represent the Italian Sleep Apnea Patient Organization on behalf the ELF, the Sleep Patient Advisor Group, and ENSAPO, our European network. Okay. Regarding the Phillips recall, patient, caregiver, and patient association are not happy with the lack of information from the manufacturer. Sorry. No, sorry. We are also not happy with having to provide the data directly to it, and our data is already in the possession of National Health System and home care provider company and sleep center. Moreover, from the information, it is safe to refer on one own clinician or sleep center, which is not adequately prepared to have results to deal with this problem created by the manufacturer. We don't know to date for each nation how many patient devices are involved. The estimated time are too long, from 12 months to 24 months, compared to the seriousness and risk for the health of a pediatric or adult patient. I have the first question. The ERS statement proposed to use an antibacterial inline filter to partially and temporarily solve the problem. Can this filter be used with humidifier, or should be used or humidification be discontinued? Also, according to the UK Medical and Healthcare Product Regulatory Agency alert issued on 23 June, the use of online filter is not validated by Philips for this CPAP BPAP machine, and it's considered an off-label use. Moreover, the benefit outweigh the risk.
Thank you, Luca. So I think we're going to go to the questions one at a time. There's also a sort of similar question from John Barry in the chat box about use of filters and humidification. I wonder if Winfried, you'd like to address that, and then maybe Sophia, and then anyone can come in with their thoughts on use of filters.
Yeah, that's an important and excellent question, Luca, and also John. We have to state that we do not have a precise data on the efficacy of the filters, but what we can say is the particles which have been found were bigger than 7 to 8 micrometer, and the filter eliminate particles to a limit of 2 micrometers. So that means the filters, to the best of our knowledge, should be safe regarding the particles. So that's one important message. Second, yes, we have to stop using humidifiers when using the filters, because humidification will lead to closure of these filters, and therefore the resistance will increase and might lead to ineffective treatment. Yes, it's also right that you can only use validated, or you should prefer validated filters. However, we have to differentiate between the devices. If you use an automatic CPAP device or any kind of automatic PAP device, then the pressure will adapt to the increased resistance. So that should not be a problem for all those who use any treatment of variable pressure support or variable expiratory pressure. However, it's clear that we should recommend replacement of the treatment or change of the treatment under close supervision, especially for non-invasive ventilation. So if there is any replacement, any change in treatment, substantial change in treatment, we would recommend to have a feedback, have a control under supervision in the sleep lab or with a sleep physician or the pulmonary physician.
Thanks, Winfried. In fact, I mean, Phillips actually guarantee that they're happy for the filters to be used in line with the ventilators and not the CPAP machines.
Absolutely.
But I think humidification can cause a problem. Sophia, you please carry on.
Yeah, thank you, Agneta. I fully agree with what Winfried said previously. The filters are carrying a lot of debate and concerns. However, especially when it comes to to be used along with CPAP and BiPAP devices. However, pandemic taught us a lot, and among these, the use of filters in non-invasive ventilator devices. However, I believe that it's a case-by-case approach, and if we use an accredited filter by the manufacturer with all the precautions and all the parameters that are referred by Winfried, and we close follow up the patient using telemedicine, telemonitoring, then regarding the particulates, maybe it's safe. It's a safe option. We don't know about the volatiles, and we may never know in the near future, but I think that if we close monitoring our patient, and if the patient doesn't exhibit any discomfort or the pressure delivery from the machine, because it's necessary to be titrated previously, then we can continue, and this close monitoring can guide us according to the frequency of exchange, if needed, earlier than month or within a week or so on. The problem will be connected to this is the availability in the end of the filters, and who can cover the filter according to different national agency policies.
Yeah, that's very true. There have been shortages of these. I don't know if Joao or Marika wants to come in, because I think we would certainly be using a filter anyway in a tracheostomy ventilated adult and child, and humidification too, but would be assessing the work of breathing, and that would be something we would be doing anyway. I don't know if either of you want to respond to that with a home trachea patient.
Yeah, so the filter is already in place in a lot of our patients, so we are quite confident that this is something that doesn't change a lot. With the humidifier, it's really the most difficult thing to solve, because we know that some of our patients are really much more adherent when we had dehumidification. So if we have to remove a humidifier just to put in place a filter, that can really be very troublesome for some of our patients. So I think that this decision, it's really a hard decision. Yeah.
I might get you quickly to comment on, there was a paper in Chess, Maxime Patou was the senior, well, the first author of that, just showing that with filters used in ventilators and CPAP machines, well, in the ventilators, there was some impact on triggering, some triggering delay, some more asynchrony, and I think inspiratory flow changed, but there were some interfaces that were worse than others. Obviously, the helmet was worse. So again, there may be something to do in adjusting the interface and the type of circuit used.
Absolutely, Anita. I think it was concluded that the double limb circuit was the best option when you're using a viral filter. And so that will even make it more difficult to change, this option, that to change a single circuit to a double limb, and some of the ventilators are not allowed to do that, as you know. So I think there are so many questions, that there are so few certainties, that I think we must have more data from Phillips. So yeah.
Yeah, okay. So we haven't quite answered that one, Luca, although I think we think it's okay with the ventilators and may or may not be with the CPAP machines. Would you like to go on to your second question?
Anita?
Yes.
One point which is in the chat several times. Of course, the filters do not do anything against the gases.
Of course.
That's absolutely clearly pointed out by some questions. It's only relating to the particles. And that's the reason why, even if we use filters, we have to replace or repair the devices until we get more information about the duration of the gases, the volatile gases. Maybe we get information that they are only on a short period of time, then everything changes. But at the moment, we have to say they have to be repaired or exchanged because of the gases.
Yes, it's only a temporary solution. Absolutely right. So next
There's
question.
also one
Okay.
suggestion in the chat about humidification that might reduce the volatile agents. There are some suggestions in the chat, and I think those are interesting suggestions, but I think we don't know the answers yet about that. We have very little information about exactly what kind and how much and how it is influenced. So I think it's an interesting point, but do others have suggestions about that? For example, we are discussing the filter issue, and I think there are a lot of points to raise. And for us in the Netherlands, we decided not to use filters because there are also a lot of disadvantages and a lot of unknowns. But this issue is also interesting, and I think we don't know yet what is humidification doing on the volatile agents.
It's a good point. And the MHRA, which is the UK authority, says some of the products disappear very quickly when the device is within 24 hours out of the box. But we're actually talking about degradation products, and some of those like toluene and toluene isocyanate. We simply don't know how long they're going to be around for. So it's a very vexed issue, and there is no correct answer to these questions. It's true. We can come back to these, but let's just move on to the next one.
Okay, thank you for the answers. My second question is, with reference for pediatric patient, do you think is a priority in an urgent replacement plan to give priority to children? Do you think it's correct that in absence of an adequate number of devices for adults, a sort of prioritization should be organized, for example, for first patients with overlap comorbidities such COPD, asthma, sarcoidosis, diabetes, hypertension, cardiac, or neurological problem? What do you think?
So this is a good one on prioritization. Refika, and there's an obvious argument to go for pediatric patients, and I think also pregnant women with obstructive sleep apnea. Would you like to comment, Refika?
First, thank you. Yes, because we are also worried about, as mentioned in the beginning by Dr. Randerhat, that because it can be size dependent, also some side effects of the volatile gases, and the children with full-time ventilator dependence may spend more time on the ventilator. So I think the algorithm that I presented, if you had one of those underlying disorders such as neuromuscular disease or central control issues that you cannot absolutely come off the ventilator and you're dependent on the ventilation device, then I would think those are the patients, pediatric patients, who need to be prioritized. And I will, of course, leave the second part of the question to the experts here.
Sorry,
Okay.
Rafika, your microphone is causing a little bit of noise.
Oh, sorry. Was it not clear? So I was just, is that better now?
I think it was clear what you said about children. So I mean, it's not really a binary whether we replace them or not, because or we stop treatment or we don't stop treatment. It's really how quickly do we replace, and bearing in mind we can't replace everyone straight away. What is the order? And I mean, I think you make a very reasonable case that children should go first. What do others on the panel feel about prioritizing other patients, or pregnant women too, but other patients with comorbidities? There is the very small subgroup of patients with isocyanate-induced asthma, and some of the products may be diisocyanate. So, you know, anyone who has a patient with that might be priority to be replaced early. But what do people think about these other patients with comorbidities? Should they be prioritized for replacement, early replacement or substitution?
I think when we set priorities, there's also one other thing, our knowledge about what age the ventilators are, what's the most, when's the risk the most, that should also be taken in consideration. So I hope that we will get more information which devices are the most vulnerable. So you also have to take that when you set priorities, I think.
That is a key question, yes. We don't know whether it's the older devices or whether it's just this ozone cleaning that could even affect a new device. Sorry, someone was going to speak.
If I may, Anita, further than what Marike said, and I agree concerning the use of time and how long they are on the ventilators or in CPAP or BiPAP, I think that there is a need for a prioritization according to underlying comorbidities. For example, a patient with excessive daytime sleepiness who is a truck driver or a pilot has to be prioritized, or a patient that has a severe overlap syndrome, COPD plus OSA, and has a severe desaturation during the night, or neuromuscular diseases, you know better than us, especially in patients that are tracheostomy. So there is a need of prioritization according to the severity of the comorbidities. However, it's not only all the comorbidities under the same severity. So we need to prioritize. I think what the pediatric field and we as in the adult area stated in the statement, I think it's suitable, and the sleep laboratories around the world can go for this after they identify their patients. We have to perform a registry to know the number of patients that are under the treatment with affected machines and devices, and of course there is a subgroup included in them according to the time of their use, because it's totally different if someone uses it for 5 years, and it's totally different if someone starts some months ago.
Yeah, and they're good points. There's so many unknowns, whether, you know, maybe the degradation has been carrying on for a month or two, or a day or two, or a much longer period of time. We don't know that. There's also the interesting question, of course, we prioritize patients for being on equipment that works effectively for them. Whether a neuromuscular patient who is continuing their treatment but on a Phillips device is more susceptible to the volatile gases or the particulate matter is an open question, I think. But Winfried or anyone else like to comment?
Yeah, I think we have to be, it's a very critical discussion, especially if you have one person in your office and have to discuss with him or her. I think it's very clear that children should be in first place, and maybe also pregnant women. Children, because they have the longest life expectancy and are most sensitive to mitogenic or carcinogenic risk. So that's clear, they should be first. Then I think we have to differentiate between the group of patients with hyperventilatory, with hypercapnic failure on the one hand and sleep apnea on the other hand. It's of course, patients with hypercapnic failure are much lower in number. That means as far as we hear from providers, different providers, they do not expect too much difficulties to replace these devices, these non-invasive ventilation devices, or invasive ventilation devices also, within a time period of 6 months or so. So that should be separated from the sleep apnea population. And then the question is to the physician, is this time enough to exchange the device within the routine period of recall? That means if the patient comes within the next 2 months or 3 months to the hospital, it might be very reasonable to exchange his or her device at that time point. And the question to the physician is only, is there a need to replace it earlier? If not, and this decision has to be made based on specific individual factors of the patient. For example, what is the life expectancy of the patient? So if you have a patient with amyotrophic lateral sclerosis, although it's hard to say, it's not very reasonable to expect cancer risk for this patient.
Yeah, this is very fair, and yeah.
And on the other hand, sleep apnea patients should be prioritized, but I think there's only a separation in maybe 3 groups. One with more complex devices, adaptive servo ventilation, bilevel in ST mode. Second, patients with severe comorbidities and severe symptoms. And third, patients with mild symptoms. And those with mild symptoms, then the risk might be higher to go on with the treatment. Whereas in the other groups, we should stay on treatment. But then the same question is, can we replace within the next 12 months when the next follow-up is going on, or should we have it earlier?
Okay, and are we saying 6 to 12 months is a reasonable time frame? We've got lots of questions coming through. Let's go to Luca's third question and last question, then we'll go to some of them in the chat.
Yeah. Did they become aware of the problem following reports from patients or sleep clinics? Or had their own internal procedure already identified a possible problem?
That's fantastic. So I think there were 11 reports we were told of, and there's about 16.5 million devices out there, and the reports are of mild symptoms of sinusitis, headache, airway irritation. Has anyone on the panel, and also if you want to add in the chat whether you have seen any of this particulate matter in mass and circuits of your patients? Sophia, have you seen this? Or
my patient population, and as far as I know, in the national level in Greece, I mean, we didn't have any referral like this yet. I don't know, even if in patients that they use their devices for more than 5 years, this is, I can give you the picture more clear in my area because we were already registered our patients. You know, in Crete is more isolated, the population. So in my patient population, even if we go back at least 5-6 years, no similar references until now.
Interesting. And I've just seen in the chat too from Sheila in Ireland saying they're considering prioritizing pediatrics, pregnant women, and those with a history of cancer, which is interesting. And then perhaps we add to that those with the older devices, although we don't actually have firm evidence for that.
If I may, Anita.
Yes, please do.
Yeah. Because I absolutely agree with everybody saying that the prioritization must be according to the disease and according to the gender or the age, and also the number of years of use. But also I think that screening for the impact of this problem on the patients would be also a goal. I mean, if we have patients with symptoms, that would be great to prioritize them. The problem is that these symptoms are so heterogeneous and so similar to the ones that our patients have that it's very difficult to ascertain that if these symptoms are related to the isocyanates or the foam particles or whatever. So I wonder if we as a board of scientific societies, we could think of any way of screening for this risk. And Professor Simons was mentioning about TDI, isocyanate, toluene, that could be identified in urine, for instance, if the exposure is relevant. And I think that as somebody from in the chat was mentioning about doing toxicological studies, if we don't have this information coming from Phillips' side and from the others, maybe we as a society could propose to do some kind of evaluation, and as mentioned, some register, because I think this is something very important for the future.
Yeah, I think there would have to be a task force. I think there'd be a registry. We could look at I mean, I think those people, the 11 people, actually had particulate matter in the circuit. So we certainly should be examining the circuits when they're discarded in more detail. It's harder we need to know more about the products to know whether we can monitor them. I'm going to go on to, thank you for those questions, Luca. There's some sort of general questions about informing all our patients. There are some individuals saying that their patients have been discharged to home care companies, or they have thousands of patients. Is it best to notify them all? Is it possible to have individual discussions with each patient? And a third point, a patient comes to you and says, I'm so worried about cancer, I need to change my device now. I'm going to go to Winfried first with those tricky ones.
Thank you. Yeah, our personal approach is we are in close contact with our national agency, the BfArM, and they are also on the same line as we as a scientific society. They do not want to disturb the patients. They do not want to make the patients afraid. They also estimate the risk of non-treatment higher than the potential risk. On the other hand, they say, well, we can't wait for indefinite time as an agency. We have to exchange devices as soon as possible, but they won't. We will have a release from the society, and this will be supported by the health authorities, and then we will. This will be the base for contacting the patients. So the first message is stay calm. Another question was how should we address all our patients? That's actually a problem. So I think it's important to have maybe a mailing with simple, clear recommendations. So stay on your device. Do you have any problems? If you have problems, contact us. If not, we will see you in the sleep lab or in the ward in the next at your next date. If you see any problems, please contact us directly. So something like that to give a first information to all patients.
Okay.
Yeah.
And I know Marika has just sent a letter out to all her patients, and then after Marika, we'll come back to Luca to find out what patients expect to know and expect from us. So, Marika, you were telling us yesterday you're doing a letter to all your patients.
Yeah, we did, but for us it's probably a bit less difficult compared to the huge amount of patients with sleep apnea. We sent a letter to all patients on home mechanical ventilations, as those are all under treatment with one of the centers. And in the letter, we wrote that our recommendation based on the current knowledge is that not to stop their treatment, and if they have any questions or want to discuss this, just to contact us. And we explain that there will be replacement, but we do not know when, and we do not know exactly how. So that's just to tell the patients that we are thinking about them and that we are considering this issue. But this is maybe far more easy for us, as we don't have thousands of home mechanical ventilation patients. We have around 4,000 in the Netherlands. And it's not so much as the sleep apnea patients. And there it's more difficult. And I think it's also an issue when sleep apnea patients are not under direct treatment in your hospital anymore. How do you get in contact with them? There might also be privacy issues for some people. In the Netherlands, it's not allowed to send letters to people where you don't have a treatment relation with, but I'm not sure. Yeah, that are all difficult issues.
Yeah, well, it's who takes responsibility for the patient, and has that responsibility been devolved to the home care team or a GP? Luca, what do patients want? and expect?
Yeah, also with the ELF, we prepare a statement we take the statement for the ERS, also with a question and answer from Phillips, and it's ready in few languages in the on page with the European Lung Foundation website. For the patient, at today, the problem is how many times we change this device. In how many times, because we know it's possible, it's more than 12 months. From 12 months to 24 months is a lot of time. Another problem is probably this situation also stop the new prescription, because the new device from the manufacturer, the device from other manufacturer, also, for the new patient with the new prescription, have also problem for have this device. We think this is another big problem.
Yeah, well, I think as far as we know, other device manufacturers, some of them have on their website the fact they don't use the same foam. We don't 100% know whether ozone affects some of their sound insulation material, but we do have others we could swap to. I mean, I'm just wondering, I don't know what others feel that Philips are going to try and replace these devices, but they've got millions and millions. They have to equitably deal with all the countries of the world. They can't just do US first or France first or Nigeria first or wherever. So whether there's a way they can recompense centers who have bought in bulk and then would substitute themselves, that may be a way forward. But you can't ask centers to pay extra money. I mean, the different payer and health service reimbursement systems, but within some health services, the ventilators are bought, or on the CPAP machines are bought in as a pool, and Philips are paid, and they would have to pay out to another company to get equivalent devices, and they would need to be recompensed for doing that. But maybe Philips have to do that because they're not going to get round to replacing these in a reasonable period of time, and we don't know what that is. You know, maybe there are other ways of doing it. Just gonna yeah, of course.
Also, we want to know a possible planning of the substitution of the device, because today we don't have more information. I think also the on-care provider or the clinician. We want to understand what is the planning for the manufacturer to resolve this problem, because we want more transparency about this problem.
And we want to know what they're looking into. So looking into the volatile products, a better understanding of the time frame. Interestingly, coming through, someone saying there are no complaints about particles in Europe, and yet Sheila from Ireland says she's one child with neuromuscular disease with particles in the mask. No reports from Ludger, who's got a lot of patients. Yes.
Yeah, because I think what Luca is saying is absolutely right, because I was revising the last FDA recalls from medical devices from last year, and what I've seen there is that when there is a recall, normally the company should give some corrective actions, and what this with this recall from Philips, there is nothing about this. For instance, you could change the software when there is some electrical problem, and normally when the device is as a failure, so they propose some corrective actions. But with this one, they just give all the onus for the medical professionals and for the patient, and I think this is really not right indeed.
Yeah, so we should come up with our questions to Philips. Just a few good points coming through from Michelle. Obviously important to have a recommendation not to use ozone cleaning, as that was thought to be responsible, I think, in about 50% of the 11 cases. And then a comment from Vicky saying a contact with Philips yesterday, they hadn't decided yet whether they will replace machines or replace the foam. But even if they're replacing the foam, they're going to have to take the device away from the patient, so they've got to be substituted in the meantime. I can't believe they're replacing the foam in the patient's home, so looks like substitution will be best. Any other questions that panelists would like to pick out? Yeah, Winfried.
one aspect regarding research. I think the most important, there are some very good recommendations for possible research activities. I think the most important fast track information would be how long are these gases given from the devices. And we are already requested this question from Phillips, and they are already, as far as I know, are already working on this. So if you get the information that there is a long-term or a longer-term release of these gases, then everything is much more difficult as compared to the situation that there's only 1 day or 2 days. Then in this situation, toxicology specialists do not have any fear about the situation. So we do not need to make urine analyses or something like that if we hear that it's only 1 or 2 days. Then we only talk about particles, but this information is urgently needed.
This I don't understand, because they say 1 or 2 days out of the box, but that's a new device out of the box, and yet the problem is we are told due to degradation of the foam, which is not going to occur in a new device. So this is something that's really confusing.
The question is if this foam, these gases come from the degradation, or is it something from the production? So like a new car smells, has a certain smell. Or if you take a new television machine from the box, then you also smell something. So that's absolutely unclear.
Yeah, actually, MHRA divide some of the compounds and say some disappear within the first 24 hours, but others, toluene, 2 types of toluene, disappear over a longer period. But this is what we need clarified.
Absolutely.
We've only got a few more minutes. There's questions too about, I'm not aware of the European Medicines Agency releasing a statement yet, but others may be. And obviously there have been helpful statements from the ATS on their website. There are comments, American Association of Sleep Medicine, Canadian Thoracic Society, but we're all fairly much aligned. So is replacement foam already available? We don't know whether they're going to be able to do that yet. So we're coming up to the hour. We can go over a few minutes. So we've got a research agenda, but if we're going to do anything via the ERS, we would have to apply for a task force or a CRC or some kind of mechanism, and then we can sort out the questions we want to ask, but we clearly need more information from Phillips first. Anything else we should cover before we end? Sophia, any issues?
I agree with the research questions and priorities that you mentioned, Anita, you, Winfried, and Johan as well. But I saw the chat something that I want to mention, that how we will avoid the panic that may be caused to our patients from the news. So I think that we have to be proactive in national level and in European level, inform patients towards the statement that from Winfried, stay calm, but provide them with proper information and individualized patient-by-patient procedure. They have to feel safe, and we have to have answers from Phillips as well. But the connection between the patient and the physician is very, very valid, and we have to work towards this independently of the workload that we have to face.
Okay, that's clear. Refika?
Earlier in the chat regarding the legal advice, so I'll just in sentences summarize. So we have asked the hospital legal team. We have created a letter to inform
the microphone is bad, Refika. There is a noise.
Okay, so yeah, medico legal. We can go a few minutes over, Ali. We should end reasonably.
So review of the letter of the medical team, so that it sounds legally sound, and shared decision making and documenting was the way that we went. And we do use the inline filters with the trilogy for all of our invasively ventilated patients already in pediatrics. Change those filters weekly, so that was the standard procedure. And we use it for humidification, and we titrate those patients with this setting, so we have not seen any problems. For the other patients, simply we just recommended to change those machines. Maybe, you know, until we know about the volatile gases, the priority for us was changing the machines that we could not use the filters with. I think that just kind of summarizes my answer.
Okay, and we might be able to use telemonitoring as well to see when we swap over. As Ali is telling us we're running out of time, I think it's also important to say patients have a right to know. Obviously, it can worry them, but the risk is likely to be extremely small compared to the risk to them of their underlying conditions. And some of them have very serious conditions indeed. So I think we have to always set this in context. Anyone want to add anything further before we finish?
Yeah, just an example from the vaccine side. I mean, we have heard about some complication, very rare, the clotting issue, and there was research coming out from independent groups that just gave us a lot of information, and that could clarify some of the risks for our patients. So I think we as a society should also be going through, I mean, with the help of the research teams on toxicology, on occupational, etc. And I hope that the ERS can just drive a good CRC to go forward on this.
Okay, and we will get back to Phillips. We've had one meeting with Phillips and there's comments too saying how crucial that is. Well, as I said at the beginning, I try to manage expectations. There are no simple answers here, but I think we have all learned a bit more about others' practice. I hope it's helped, and I think we probably need to return to this topic over time so we can continue to share experiences. So thanks ever so much to all the panelists, and thank you, all of you, for participating and watching from home, and good night.